Case was a 92-year-old female. Her chief complaint was dyspnea and peripheral edema. She was referred to our hospital because of worsening dyspnea. Her condition could be classified as the New York Heart Association Functional Classification 4. She had a medical history of hypertension and diabetes. Although she was diagnosed with symptomatic severe aortic valve stenosis 2 years ago, she did not want to undergo surgical AVR nor TAVI. This slide shows her physical examination, very small old lady, and I heard ejection murmur and nail and peripheral edema. This slide shows chest X-ray and ECG. Chest X-ray shows pulmonary edema, and ECG shows CRBBB and sinus rhythm. Laboratory data shows very increased BNP level. TT shows decreased EF. Her EF was 40%, but 2 years ago admission, her LVEF was 60%. And CVIS, aortic valve area, was 0.4, and peak velocity was 5.4, and mean pressure gradient was 77 CVIS. This slide shows a clinical frailty scale. Her clinical scale, frailty scale was 5, but due to heart failure, it was to 6. After admission, she was resistant to conventional medical therapy with NPPV, furosemide, tolvaptan. Tolvaptan is anti-vasopressin receptor. It's commercially available in Japan for heart failure, and dobutamine. So heart failure getting better, but easily worsening without any exertion. So we consider TAVI or surgical AVR for her, but her STS score was 25. Our heart team considered that she was candidate for TAVI. Unfortunately, we could not perform TAVI in our hospital at that time. So I talked to Dr. Yamamoto, first presenter. I used to work with him. His hospital is TAVI center, so he told me to take her to his hospital. So I decided to transfer her by myself. Yeah, it's, but Japan is a small country. It is smaller than California state, but there is many mountains and the road is very small. So if I transfer her by car, ambulance, it takes 8 hours, but using helicopter, it is only 90 minutes. Yeah. Just after arrival, the same day, we performed the 3D CT to evaluate aortic valve complex, coronary artery, aorta, and iliofemoral arteries. So after that, we do TAVI, TF approach. Light CIA was 5.5 by 5.5, but there is heavy calcium, so it is difficult to pass the CIA, but we could make it. And after pre-dilatation, we implant the 23 millimeter Sapien 3 valve. After that, there is trivial perivalvular leakage, no transvalvular leakage. So we finished procedure. Hemodynamics changed, getting fine. After that, after TAVI, she was discharged at 7 POD without any complications. She felt so happy because she could be free from dyspnea. 2 weeks after discharge, I saw her in my outpatient department. She has no symptom, and chest X-ray is normal. After TAVI, the LVEF increased to 60%, and serum BNP level decreased to 220. I saw her in my outpatient department once every 3 months. So now she's 94 years old. She's getting fine. The last month I saw her, and she forgot her walker in my room, and she walks by her own foot. So it's very good. Transcatheter aortic valve implantation becomes a popular treatment for patients with severe aortic valve stenosis deemed high or prohibitive risk for surgical aortic valve replacement. Although previous researches reported the effectiveness and safety of elective TAVI in septuagenarians and octogenarians, it seems to be still controversial in nonagenarians, especially emerging case. We had a case of successful emergency transcatheter aortic valve implantation for a 92-year-old female with severe heart failure. Thank you for your attention.
Maybe it's a totally stupid question, but I saw many cases now from Japan during this meeting, and it seems like you guys have a lot of heavy calcification throughout the vasculature, coronaries, aorta, valve, all the endothelial sides. Maybe I just don't know, but why is that? Or is it just coincidence of these cases that you
why they have heavy calcification?
Yeah.
I think one point is they are very high age, and they have hypertension and or diabetes. So, and they live longer because they have maybe they have few incidents of coronary artery death, so they can live a long term. And after that, the aortic valve stenosis getting worse. So maybe they have severe calcification.
Great job on that case. Do you think there's a role of maybe doing a valvuloplasty to help patients get a little better and maybe have a safer transfer, or do you guys practice valvuloplasty there?
Yes. Thank you for the question. We discussed same things, but this patient has no AR before TAVI. So if AR getting worse, she failed to crash, and hemodynamics getting worse. So we might lose her. So fortunately, using dobutamine, her heart failure is we can control her heart failure. And after using dobutamine, her LVEF getting better. So TAVI is best therapy for her, we think. Thank you.
How many patients have you flown?
Yeah.
Do you fly a lot?
Yeah, well, no, I fried.
Did you transport her? Were you the one that transported her to the facility? You flew her yourself?
No. I'm not pilot. Thank you.